Hi, I'm Beatrice Seguin, PhD. What used to be that time of the month is now this time of the month. Welcome to our community, a curated space for everyone going through perimenopause and menopause. A place where we can find support, good laughs, great tips on products, and lots of education on health. There's beauty in aging. Whatever beautiful means to you, this time of the month will help you find it and live it. The content expressed in this time of the month is not intended to be a substitute for medical advice. The views and opinions expressed on this show are those of the speakers.
Today, we're here with Dr. Audrey Li. She is a gynecologist, radiation oncologist, and she'll tell us more about what that is. But the focus of our conversation is about premature menopause, specifically related to cancer treatments. So welcome, Dr. Li.
Thank you. It's so awesome to be here.
Well, I think that we want to tell the audience that, there's a lot to consider around menopause.
It's true.
Yeah.
But we normally consider menopause in terms of the natural way that all women go through it. Mm-hmm. But in the job that I do, which is doing cancer treatment and radiation specifically, I see a lot of people that we put into premature menopause because of the treatments that we do, either with surgery or with the chemotherapy, or in my case with radiation. And so we see these lovely patients who have to struggle with symptoms that they wouldn't have expected until much later, and sort of having to deal with how that affects their quality of life and how they go through sexual activity and just how they feel about themselves. And that's more than just the treatment, and it's more than getting through the cancer stuff. It's like how they live going forward.
Mm-hmm. So maybe walk us through that, cancer in general, then what's the different therapies you just mentioned do, and then what the consequences are.
So sometimes we have cancers that actually affect the gynecologic area, which is what I treat. So uterine cancer or cervical cancer primarily are ones that I kind of deal with, where because either the surgery or from the radiation, we either take the ovaries out of the patient, or exposure to radiation for the ovaries help them, stop working, which is an unexpected but not necessary part of the treatment. And then we have other people like with breast cancer who, because of chemotherapy and sort of the treatments that we give people, where we want to suppress their estrogen for their treatments, that also puts them into menopause. Sometimes reversible, sometimes not so much.
So that must be really hard because you're dealing with your own cancer and now you have on top of that symptoms. So is it worse for a patient with cancer?
I think that it's twofold with people with cancer, because the first they're dealing with a diagnosis. And there's all of the psychological stuff of dealing with being diagnosed with cancer, going through the treatments. And so that's a big part that people are, when they get set with this journey, they say, okay, well, this is what I have to get through. And all the other stuff in terms of symptom stuff is almost an afterthought in many ways. They're just trying to get through whatever treatment plan they've got. But it starts coming up when you start having, let's say, chemotherapy, and suddenly, because of the lack of estrogen, they're having hot flashes. They're not sleeping at night. And so you have the side effects of the treatment, and you also have the unexpected side effects, such as the hot flashes. And it's a double whammy, if you will, that you are struggling with trying to cope with a disease process, and then also dealing with all these side effects. And at the same time, it also changes sexuality, because you are trying to get through a very stressful time. You may not feel like having intercourse or sexual activity. And at the same time, when you try to do it, it's dry, it's uncomfortable, it hurts, like you've had surgery, you're afraid of all that stuff that goes in. It's very, very complicated. And it's hard when we, as practitioners, focus on the treatment and getting people through, but the quality of life part inevitably weaves itself in.
So how do you help your patients manage that? How do you communicate with them, and what are some of the things that they can do?
Because I do radiation treatment, I do focus on people getting back to sort of their normal activities, because getting that part of your life back is very important to kind of move forward. And with sexual activity, as an example, I stress the importance of lubricant when you're having sexual activity. Picking positions that you're comfortable in. Trying to not be super stressed about being in that situation. If you're not comfortable, it's okay. Take the time. Baby steps, that sort of thing. But it often is. There's so many different facets that this kind of impacts. As an example, the vaginal dryness can also impact your urination. So people complain of, having to go more often. Infection-type symptoms, which aren't really infections because the tests are negative, but they're still struggling with that same symptoms. And I'm okay. Are you drinking enough water? Have you tried cranberry? Have you tried probiotics? These sort of
maybe stay there because maybe not everyone knows about that. So do you want to talk about just our hormones, our anatomy, and then?
So this is sort of something that I found out myself going through this perimenopausal time, where I was struggling a few summers ago with these urinary symptoms, and I was having all this like painful urination and having to go more frequently, and it was honestly driving me crazy. And I also had like urinary tract infections, and so I happened to mention it to one of my friends who's a gynae oncologist, and she was like, "Audrey, do you not know that when you're perimenopausal, you don't make as much lactobacillus?" I was like, "Oh, what are you talking about?" So I did my own research, and sure enough, when we have less estrogen, we don't make as much lactobacillus. So all I did was take a probiotic that had cranberry in it, and suddenly I haven't had any symptoms since then.
Maybe explain to our viewers lactobacillus.
It's one of the good bacteria, if you will. It's often, in some of our yogurts and things. I would not take them any other way, except for orally, because I've also been asked these sort of interesting questions from patients. But it's a very important part.
Good questions to ask.
Yeah, absolutely. If I lack lactobacillus, why can't I put it in my vagina? Well, it's not something I would normally recommend. You can just take it orally. It should go everywhere and get your normal ecosystem of. We all know about gut and colon ecosystem. Vaginas are not that much different, really.
So taking some cranberry probiotics can be helpful to reduce.
The supplement that I found, because the cranberry we know can increase the acidity in the urine, so it's less hospitable for things to grow in. So I often use cranberry anyway. But there was one supplement that's had both in it, and so I was like, oh, good one-stop shopping. They're often marketed under women's probiotics, if you will.
Okay, and maybe is there a distinction with the kind of sweet tasting? We don't need to name brands, but cranberry juice, which may be more. That's not the same as the pure cranberry. Is that correct? Or
correct.
Yeah,
I tell my patients cranberry cocktail is only good with alcohol. It doesn't really have the cranberry juice in it. I don't know if anybody's actually had real cranberry juice. It's actually very hard on the stomach.
It's tart.
Yes, it's very, very tart.
Yeah.
And so then you end up chasing it with water, which is fine. But I like the easy taking, and then you don't have to worry about it. They do make cranberry gummies as well, which are very tasty.
Oh.
But then it's too much good candy.
Not a bad treat sometimes. So do we want to go back a little bit then in terms of estrogen? And in the context of cancer, and in the context of well-being. Do you want to walk us through that? And other hormones. I'm focusing on estrogen, but anything you think is relevant to.
Well, estrogen, primarily because that's what we, relate to menopause. If we look at somebody, as an example, with breast cancer, who is, I would say, almost reversible menopause, in that we do, for some time, take away their ability to produce estrogen, and then at some point when they're done treatment, it comes back. And so that's almost, you have, what can you do in terms of the side effects in the short term, knowing that maybe it'll come back. And so our younger patients struggle with that as well, because they're trying to have kids, as an example. So estrogen, in terms of their ability to, they can't be pregnant during their treatments and stuff. So that's a difficult thing for them as well. And then obviously the side effects of menopause, in terms of hot flashes, not being able to sleep, decreased bone density, decreased muscle strength, tired, which are all things we see when it's so-called normal. But these are young people that have kids that are trying to work, not sleeping. That's very interesting. And then when we look at from a treatment, from a radiation perspective, or from surgery, when people have uterine or cervical cancer, and we're actually taking the ovaries out or rendering them completely not functional, then that's almost what we premature early menopause. And then they're going to struggle with these both short-term and long-term things of not having estrogen, where we would expect them to have bone density. So I always counsel, take your vitamin D, resistive exercise, strength training, and that'll help with fatigue. And also sometimes these hot flash symptoms also go down when people are exercising as well. And then you have the sort of global improvement of exercise always is good for many things.
What about, so if you're having some symptoms and you cannot provide hormone, what are some of the other things you would do then to alleviate, in addition to what you just mentioned, alleviate symptoms?
So I advocate about a lot of exercise, and we've talked about the probiotics. Things like lubricants or vaginal moisturizers help with the sort of the symptom kind of things.
What's the difference between a lubricant and a moisturizer? I'm not sure people would know that.
So we moisturize everywhere, and it turns out you can actually do that in the vagina as well. And most of the moisturizers that are available are, every 2 or 3 days you can put it in before you go to bed at night, and then that.
Is it in
it's
a
it's a capsule?
Capsule.
So which is why you have to put it in before you go to bed at night, so it doesn't fall out.
Okay.
And lubricant for a sexual activity is to make it more comfortable all the time. And in fact, for my patients who have had radiation, I actually give them a dilator to keep the vagina open as well, in order to make sure that the scar tissue doesn't
Darn, it would have been great if you brought one on. Maybe not everyone knows, but they are inserts that are silicone-based or something,
It's, I joke with my patients, it doesn't have the bells and whistles, but it does a similar thing.
We'll have to bring one on the show.
We should.
Well, I'm curious, because I imagine in a cancer center, we are in Canada, but perhaps, correct me if I'm wrong, there must be resources for patients with respect to some of these discomforts and struggles of sexual wellness, sexual pain, all of it. Do you think they're utilized, underutilized? Tell me about that.
I think that overall, if we're talking about a sexual activity, I think overall people, in terms of medicine people, are very uncomfortable with talking about intercourse or talking about sexual activity. They really want to focus on the treatment and the patient's prognosis and their outcomes, which is great, except for the people that you're treating have to live a life, as normal a life as possible going through that. At our center, we actually have a sexual health clinic. And so there are many centers that are looking at survivorship and how do people live with what the symptoms we've given them, and sexual health is one of them. It's probably, not as common as we would hope, but I think it's starting. I think talking about it is the first step, and increasing, doctors and nurses and other people's comfort level with discussing it. We had a program with radiation therapists, trying to get them more comfortable with talking to their patients about what happens afterwards and stuff as well. So it's an education perspective from a practitioner part as well as from a patient part as well.
It's fascinating that as a scientifically, medically, anatomically trained professional, it's still uncomfortable for the provider to bring that up. Imagine everyone else. I mean, it's so hard, but I hope there's awareness and talking.
I think we start having a comfort level or not having a comfort level of discussing intercourse or sexual activity to begin with. And I mean, I've made it my sort of goal to make sure that I get my patients to be comfortable talking about these sort of things, because they may not be able to talk about other people as well, both men and women, honestly. But we've got to start somewhere. It really is an important, for some people, not everybody, but an important part of life, I think.
Well, we're thankful for people like you who are comfortable, because the more we talk about it, hopefully we realize we don't have to live, right? But you say that some of the key messages, what would be some of the takeaways you'd want our viewers to leave with after hearing you today?
I think that it's not just the cancer journey in terms of what we see as diagnosis and treatment, because the getting through all of that with as normal of a lifestyle and normal quality of life as possible helps you get through the journey, if you will. And talking about it is the first step. And asking the questions, because if somebody's not comfortable with it, or that's one way that they can become more comfortable with dealing with issues. We do have lots of support groups and people to talk to, but it's asking. And not everybody's comfortable asking, and you're kind of concentrating on trying to get through things, but you want to be as normal for you as possible. And that can also bring happiness and, reassurance. And we all need all of that when we're going through these difficult times. Everybody does, I think.
Yeah. Are there resources that people can look at or refer to with respect to cancer and sexual wellness? Would you want to point to any? Or?
I generally go to Cancer Care Ontario, which has a lot of resources, both for treatments and for these sort of support kind of issues. Every hospital has some kind of things that you can go to. Gynecologists often have things, but for us, I rely on my gynecology colleagues, my surgeon colleagues, who have been trained in gynecology as well, and have given them lots of information, like the probiotic thing, which I had no idea about.
Let's switch gears a little bit, because I'm interested in exploring you are a professional that cares for cancer patients, but you also are a woman. Your own lived experience, did you growing up did you hear your mom talk about perimenopause or menopause? Tell us a little.
I come from an Asian family. We don't talk at all. It's a very, very, not conversation about any health or anything, honestly. I learned about intercourse and sex in sex ed at school. We never talked about it at all. When I asked my mom recently about menopause, she said, I don't even know what you're talking about. I don't know what these people are talking about. I never had anything of the sort. What is this menopause thing? She had no idea. And part of it, I think, when she may have gone through menopause, my father had just passed away. She was grieving about that. And I think probably that was a little bit different for her, because she was concentrating on something else that was really big and didn't probably pay attention to herself at all. But she had no idea. So I have zero stuff from my mother or from anybody really going through menopause. I don't think we ever talked about it. And it's only now, when relatively recently, when I was starting to get symptoms, and then my cohort of friends were also having symptoms.
All the texting that we do, yes.
And then suddenly, oh, this is what I'm feeling. Somebody else is feeling this. And there's nobody else, no one's talking about it. And how is this? And you talk to my older patients, it's just something you just need to deal with. And I was like, but you're feeling all these sort of symptoms. Yeah, well, we just don't do intercourse. We just don't do this. I live with the hot flashes, they're horrible, and then you move on.
And I won't sleep for the next 10 years, and it's
Correct.
Fine.
Yeah, builds character.
Do you think that's a generational thing? Do you feel like, again, we're Gen Xers?
But I feel like
we're no, we're not putting up with it.
I'm like, why do I have to live with this? This cannot possibly be. There must be we're resourceful people. There must be something we can do. And I think maybe, I don't want to call people passive, but I think, it's your lot in life. This is what you have to deal with. And honestly, the medical community, not so supportive of, treating things in terms of menopause. It's a normal, everyday wave that happens. Natural. Let it go.
This might come up more than once, because I've really been reflecting on these definitions. Natural versus condition versus, the word pathology in the context of our Western medical care system. But, it's natural, but yeah, did humans live till 100? No. Does it mean it doesn't deserve condition? Not condition, deserve care, right? So, yeah, what do you think from that medical community perspective? What's the conversation like there?
I feel like overall, we do live longer than we used to, right? That in the past, people died of war, infection. No one really lived long enough to get cancer. No one really lived long enough to get menopause, as we see now. And then the medical community, for a very long time, was generally less women.
Yeah.
So the perspective is a little bit different because the, thought was it's what women should go through. And you don't have the advocates in the medical community to kind of say, hey, what do you do? Obviously that's changing now, but I still think it's a little bit taboo. Like, I feel like the interest is not there. It's only from people who ask again and who are advocating for something to do that are going to drive the talk, drive the action, if you will.
I love the drive the action part. In terms of driving action, do you think that going through perimenopause yourself is changing the way you practice?
Absolutely. Like, I think I ask more about how people are managing with hot flashes. I advocate for probiotics, not infrequently now. I have a greater appreciation for my younger patients who, were struggling with hot flashes, and I didn't know how bad they could be until relatively recently. And it's horrible.
They're horrible. Can we just say they're terrible?
They're horrible. And they come and I had no idea. I really had no idea. And now, when you experience it, you have a great appreciation. I wish I had known earlier and asked more and offered more now, rather than just said, oh, it'll get better, or you can just manage, or.
And this whole get better thing, do people realize that it can go on for decades? Like, can we have hot flashes all the way into our 60s and 70s?
I had a patient last week who was 76 who had hot flashes. So it absolutely can. Absolutely can. And she's like, well, I've been dealing with this for 20 years now. I can manage them. But yeah, she's a wonder. She was a wonder. I can't even imagine. Because the thought is that at some point it does stop. And for some people, it really does not. And if you look at somebody who had cancer treatment and, had premature menopause at age 30.
That's a long life.
That's a long life.
And what do you do there? You can't, the recommendation is not to be on, for those who are eligible, to be on hormone therapy for 40 years. Like, is there anything?
So I counsel my young cervix patients, as an example, who I've knocked off their ovaries with radiation, for lack of a better word. And I replace their estrogen because they would have had estrogen until 50-ish.
Okay.
And so I absolutely basically do either the birth control pill continuously or their patches. And so we do replace our estrogen. But that question is going to come up at some point because they're going to live longer and survive. That's what we hope. And when to stop. I absolutely.
Do we have the data?
Not yet.
Not yet.
Not yet. And
why?
But remember that HRT in the old, there were people who took HRT till their 80s, right? And they looked like they were amazing.
This was pre-90s Women's Health Initiative scandal.
Right, right. They took, you had to grab them from their dying hands. There's lots of women still like that. So maybe, with the controversy of the Women's Health Initiative, maybe we do it a little bit longer for symptoms, but we don't know.
Are there any clinical trials right now that you are aware of that are looking at this long term?
Not that I know of.
Why don't we have these types of studies? This is not new. Menopause is not new. Women's health is not new. It is not a niche market. It is not a niche where 50%. What?
Isn't it terrible that a lot of the studies that are proposed these days are pharmaceuticals, right? There are the ones that have funding behind them. It's so hard to launch such a huge trial that doesn't really look at, and estrogen replacement is relatively cheap now, right?
Yeah.
So they wouldn't make any money from it, and then we'd end up with some sort of cohort kind of study, which is not as powerful.
Right.
But it's not popular, right?
Because segmenting a study would be too expensive to segment by all kinds of factors.
And even just to mount any sort of study is so expensive that trying to get funding for it is difficult. But it's an important question, and the problem is that we're still tainted, if you will, by the myths and in the controversy from that study. So there's people that firmly, like I have patients who are young who are in their 30s that have had their ovaries stop because of me, and they don't want estrogen replacement because they're fearful of the potential risks of increased breast cancer or having heart issues or whatever.
Do you think that in the recent year, I would say there's a bit more awareness in the media? It almost feels like it's way harder to undo a negative headline that was from the 90s that's lasting decades.
Well, we still don't. Yeah, we still don't want to do vaccines from like a very wrong thing. This is not that scale, obviously, but it shows you that one study can change the landscape, and then trying to build yourself back from that is difficult. Small steps, still worth doing, but it's an upward battle.
It's an upward battle. So I hope we create more awareness. And so if you were going to bust some myths, do you want to bust 3 myths for us around menopause, hormones, and cancer? That's a tall order.
It's a tall order. No, such a nice
Give it a try.
Having estrogen replacement is not always a bad thing. That in a reasonable, well-informed discussion with your practitioner, weighing the risks and benefits, being on estrogen replacement is not necessarily a bad thing.
Okay.
And I would advocate for it, at least having the conversation. It's not right for everybody. And there are potential risks for breast cancer, and so there's a screening and all these sort of things we have to push through, but that's the main one. I think we have to get back from this whole no. I still have colleagues who refuse to have any discussion about estrogen replacement. I mean, they're breast cancer practitioners, but they won't even consider it. So we have to start somewhere. I think having the discussion and making informed choices is important. I think that one of the that drives, in terms of myths, like the practice for many people, and how do we get practitioners to change is important, because there's going to be people who want to have stuff done, and you have to, respect that, I think. Another myth, that's estrogen replacement for somebody who's menopausal in any way, shape, or form. I also think that just because you've had cancer treatment and stuff done, that you are worried about surviving. I think people have to worry about living.
That's so beautiful.
And I see this all the time, and it sometimes breaks my heart, but we really need to live. And you're going to be done your treatments and done your journey, and you're going to be left with what? And so you have to work on that all the way through, I think. It's not really a myth, but it's it's a
mindset change.
Yeah, it's something that I see people struggle with every day, honestly, and it's hard. That was 2 things.
Well, those were really good. Maybe we'll be happy with 2. I forgot to ask something earlier. You're talking a lot about treating patients with cancer. Is there a red flag just for the general population? Say that I don't have my period for 12 months and then later on bleed. You want to tell us what that means? Or
always after you don't have your period for at least a year and you get bleeding, you immediately have to get, not immediate, like tomorrow, but absolutely seek medical attention and investigation, because we learned in medical school, bleeding after somebody hasn't bled for a year in menopause is endometrial cancer or uterus cancer until proven otherwise.
Okay.
So that is absolute. The more subtle ones are people who have heavy bleeding and then don't have heavy bleeding and then have heavy bleeding again. And I would also urge people in that sort of situation to get investigated as well, because there must be sometimes a reason for people to have what we call dysfunctional uterine bleeding. Really heavy periods, crazy heavy periods. I would also have a look-see.
Okay. Good.
And the other thing is that people have to have their pap smears done.
How often should we do that? Let's go 30s, 40s, 50s, 60s, beyond.
Okay.
Is there a difference?
unfortunately, the recommendation is every 3 years for pap smears, which drives me crazy since we didn't remember to do pap smears every year before. And now, or at least our government is doing similar as breast cancer screening, cervical cancer screening. But there are times where people say, okay, well, you're 60 or 70, you don't need pap smears anymore. I'm not sure I agree with that. Okay. And that might be because of what I see all the time. But, I think
fair statement.
People say, like, well, I'm at a certain age, I don't need mammograms anymore. I don't need to have my pap smears anymore. Preventive or screening is so that you can stop something early. Mm-hmm. And it's relatively easy.
Yeah, and the HPV vaccine did not exist for generations, right? Whereas the younger generations have HPV, so that will offer... Do you want to talk about that a little bit? I mean...
This will hopefully put me out of a job at some point because I have to work till I'm 95. Freedom 95. But I look forward to the time where our kids are not going to have to worry about cervical cancer or head and neck cancer or vulvar vaginal cancers because HPV will have knocked that out. The ones that are offered at school are the more simpler Gardasil, which is 4 subtypes. There's one that's 9 subtypes, and I would advocate for both men, both boys and girls to get both, to get the more broader vaccine. But I'm hoping that at some point, I will not have a job. That'll be great. Yeah. And that would push me to early retirement.
It's interesting that you mentioned the HPV vaccine for boys as well as girls. Maybe our audience doesn't know why it would be important for boys to get that vaccine.
It's an excellent question. So it launched, obviously, for girls because the primary focus was cervical cancer. What people don't maybe understand is that HPV is actually for a number of cancers. So for women, cervical, vaginal, vulva. But also for things that impact men as well as anal canal, which is both men and women, and that's also HPV related. And also head and neck cancers, some of them are HPV related as well. So it's not just women, it can impact men. And for lack of a better description, HPV is a sexually transmitted disease. Women can get it from intercourse with potentially men. So both people, men and women, I would advocate for basically vaccinating both.
Men with men and women with women.
Absolutely. There is transmission of HPV in multiple ways. And what is a little bit frustrating is that the same anti-vaxxers say, okay, well, no, I'm just going to have to put more pap smears. I'm going to just do more surveillance. The problem is that these cancers have a significant impact on mortality, obviously, but also, morbidity. So there is side effects. There's all these things that we do to people to help, yes, cure their cancer, but that affects people. So if we can prevent that, if I can prevent my daughter and my son from getting these things, absolutely.
Prevention is
always key. Again, I don't mind not having a job.
Another thing, is it too late to get the HPV vaccine? The campaigns are aimed at teenagers, but what about these generations that,
so that's been a bit of a moving target because, we concentrate on our younger people. The fact of the matter is that the new vaccines cover so many subtypes, so 9 subtypes, and I think, we'll see that expanding as we go forward. Those 9 subtypes are ones that are more related to cancer development, and we are not necessarily exposed to a certain subtype or whatever. So the recommendation is 9 to 45 currently. I've had patients older than that who pay for the vaccine just as a peace of mind. Even ones that have had cervical cancer who know that there are other subtypes that are going to potentially impact them further have also had the vaccine. So I think, if you're interested, go talk to your practitioner, your family doctor, your nurse practitioner and say, okay, what can I do about this?
Find out more.
It is not covered. So
in Ontario.
In Ontario. Okay. So it is a prescription that you have to pay for in your drug plan, hopefully, if you have one. But it's absolutely a huge investment that's totally worth it.
But for those of us who did not have that vaccine because it didn't exist, pap smears.
Pap smears are
really important.
Really important.
Okay, so don't skip it. Post-pandemic, do you feel like we're in a time warp? Because I feel like, do I remember when I get a pap smear? I don't remember. Are people forgetting, or
yeah,
the
people
reminders? Yeah.
Well, if you, I don't know how broad the cervical screening mailing is for the, as yet. I mean, I got something saying that I was due, but I'm not. I'm hoping they're pushing it out more. It's hard to pick up on people. It is. It really is. It's very challenging. And it's so, if you don't remember, call your family doctor or call your nurse practitioner and say, hey, when's the last time? And if you don't remember, just have one done.
Yeah.
I think there should be like mobile clinics.
Mobile clinics would be brilliant, wouldn't they?
Yeah. Or like, we do vaccine clinics in the workplace, so just have a pap smear clinic.
There's a thought.
There's a thought. Probably not a popular one.
We're going to do a little bit of just lighter stuff. Cancer can feel, it's good we're talking about it, but it is heavy. Let's do a little bit of this or that. I feel like you might like the this or that. Negroni or martini?
Negroni.
I knew that. I knew you would say that. Sweet or savory?
Savory.
A dog or cat?
Dog. You have both. You're lucky.
I know.
You don't have to choose.
And the cat does make occasional appearances on the podcast. Books or movies?
Books.
Okay.
I have a hard time sitting through a whole movie these days, or for a long time. Etienne will tell you I can't sit through a movie. Books are easier. They're a little bit more bite-sized that I can actually get at when I need to get at it.
Is there anything that I haven't asked that you think is important for our viewers to know?
Be true to your old self before you had the cancer, because you're not a different person just because you have a diagnosis, either from anything, cancer or whatever. Be true to who you were, and that just because you've had something happen to you, cancer or otherwise, that doesn't change who you fundamentally are. And you forget when you're going through stressful, rough times. So I always tell my patients, what did you used to like to do? What did you used to enjoy that you can't find now with the things you're going through? Go back to that. If you used to like going for a walk and you spent, and that got you to ground yourself, go back to that. Find something that you can go back to kind of anchor yourself to the way you used to be. And this journey is a journey. It does come to an end at some point. And then you want to be closer to your pre-diagnosis than you were. Far away from it.
That's great advice. I like to ask all our guests this last question. What makes you feel beautiful?
Isn't it a funny thing? The last step that I do when I'm getting ready in the morning, the start of my day, is that spritz of perfume. And it finishes my morning routine, and it gives me confidence and makes me feel special and makes me feel beautiful. And it's the strangest thing, like it's just one cork, but it's a spritz of perfume. Wow. And I can smell it and I'm like, oh, okay, I can start my day.
That's a beautiful. It's not corky.
It's corky.
No, it's not. And your intelligence, your energy, your compassion, and your advocacy is inspiring. I thank you for being on this couch with me. And I love you. There's shit I like, and then there's shit I'm obsessed with. And I'm from Montreal, and there is a luxury brand there that if you don't know about, I'm here to share. La Maison Chane is a Montreal company founded by a woman, Chantal Lévesque, and it creates beautifully crafted wow effect swimwear that will last forever, but it also has beautiful clothing. So if you're looking for anything with fine detail, high quality, and highly expressive, Chane is your brand.